Bonjour tout le monde. Hi everyone. Hi the big Broadbent family. I know like all of you, we'd all want to be at a conference. It's been for a few years now, one of the highlights of my career to attend one of the Broadbent Summit. Now we're doing this virtual dance and we'll deal with it for a while. Imagine the start. We had Mr. Broadbent, André Picard, Amit, Charlene, so Dan, Amira, Jeff, we better perform here. Andre asked us, will the pandemic give us the backbone to change things? Medicare 2.0. Charlene said that, well, premiers will need to be bold. Well, honestly, Charlene, we'll need to change a few of them if we expect changes for Medicare point two. But let me introduce the topic first. The broadband team and my team at CFNU gave me so many papers, and I said it's only an intro. But last fall, the Broadbent Institute came out with a research paper on Medicare point two. Goes way back to Tommy Douglas, and we're not going to give you the history there. But the first thing was to talk about mental health services. We've had a commission in Canada for over 10 years to talk about the need of mental health services in Canada, to integrate it all with our physical health. Are we there yet? No, we're not. We need to legislate coverage, and we'll talk about this. And then long-term care, you heard the previous panel talk about long-term care. And if COVID-19 didn't teach us anything really, we need to bang our heads on the walls because long-term care is, and if we don't do anything, we'll remain in a crisis. I chuckle when Charlene mentioned Australia, because Australia had a big campaign on long-term care, and it was, imagine, we have standards, we have quotas for children, for childcare, but we have no standards, we have no quotas for our seniors. Let's shake our heads again. We'll talk about universal public pharmacare, and that's another one that we're wasting billions with millions of families that don't have proper coverage and only end up in hospitals. But I'll let my experts go into that area. So my experts, quite lucky. I have a whole crew of experts. I have Dan Raza, who I love his intro. He says he's a physician. Of course, it's marked DR before his name. We know that. He's an academic. He doesn't like to brag about that one too much, but he's an advocate. I've met Dan when he was a baby doctor, and he's been an activist since then. He's a family physician at St. Mike's. He's a professor or assistant professor at University of Toronto. He was the past year of Canadian Doctors for Medicare, and he loves the advocacy and the evidence base. And then his bio goes on. Then I have Dr. Amina Jabbar, the geriatrician from the Greater Toronto area. I haven't had the pleasure to meet Amina yet, but I will. She's a former social worker working with marginalized population. She loves to study. She did social work, then she went for a Master's of Science on the evaluation of healthcare services. Then she went to medical school at University of Toronto, and now she's currently doing a PhD in health policy. Told you she likes to study. Now we have Jeff Ansloos. You'll have to tell me how to pronounce your name, a community mental health expert and the Broadbent Institute director. Jeff is a leading public scholar, a writer, a policy advisor in the area of youth, social policy, mental health, Indigenous rights. You don't waste any time, Jeff? No boring life for you. He's a assistant professor at University of Toronto. And of course, we had to have one author at least on this panel. He's the author of Medicine of Peace, Indigenous Youth, Resistant Violence and Decolonization Healing. Okay, mouthful here. And he's a commentator on the Maclean Magazine and the Huffington Post. So my panel is introduced. So now I follow my notes. The first question for the panel is, again, to look at Medicare. We all of us, I look at your age group, and we've all lived under a Medicare system in Canada, at least. And we've had national debates for decades. What has changed most for you in this conversation as a practitioner or as an advocate over the last year of the pandemic? Now, who wants to start? I will go to Amina since I go with my sister.
Thank you. Thank you for that lovely introduction as well. And one of the things I'll mention, just to give you some context, is um, as a geriatrician, I specialize in the care of older adults. And so my practice really spans the gamut. Most of it is in the Peel region, which we know has been really hard hit. And I see people from in the hospital to clinics, and I still do some home visits. And the thing that's really remarkable to me, that struck me over the past year, is how thin and fragile our social safety net is. I have had patients of mine who have been crisis listed for long-term care who have been waiting upwards for 8 to 12 months for a long-term care bed. I've been helping try to treat people with advanced dementias at home with families who are really burnt out. And if anyone here has had loved ones with advanced dementias, you're talking about people who often have paranoias, delusions, or wandering. Those are really, really challenging things to deal with. And I think it's really, really struck me how thin the services are again. And it's been very challenging for families to make ends meet.
Thank you. You're right. And we'll talk more later about the burnout. You talked about families burnout. We could talk about staff being burned out. Dan, let's go to you. What have you seen a big difference in the last year with the pandemic and your thinking of where Medicare should be going?
Well, I think the last year has really highlighted both the really, positive things that have been happening in the healthcare system, but also some of the, really large gaps we need to address. So, I like to think I'm an optimist, although sometimes, the past few weeks are getting the best of me. But, the pandemic has really shown how dynamic our healthcare system is and how dynamic our healthcare leaders are within that system that are working hard to make it work. This third wave has been crushing, but we've seen people come together and create this incredibly complex transfer system from hospital to hospital, region to region. And we've seen that level of integration that, the times have demanded, and people have risen to that challenge. Early on in the pandemic, we saw this incredible shift to virtual care. I'm a family doctor. It fundamentally changed the way that I see patients, and we saw what would have otherwise, I think, taken a decade happen in 4 weeks. It was incredible to see that. Mm-hmm. And we've also seen, and this is has to do with the fundamental principle that underlines Medicare, that access is based on ability to pay and not need, that's being preserved through the pandemic. So early on in wave one, people were really scared to come to the hospital, and we had to work through people's fears so that they felt safe coming to the emergency department or coming in to see me when they needed to do it. But we also didn't have to overcome this fear of bankruptcy or costs at a time when people were also losing their jobs. So that, I think, for me was really the highlight. But there's also been some really unfortunate lowlights. And they've been in the same areas where there have been the highlights. So if we again turn to virtual care, I think that's fundamentally changing the way that we do healthcare. But at the same time, because things are moving so quickly, it's also created an opportunity for really large companies and corporations like TELUS and Loblaws to make really big investments into virtual care. And I think we need to be very concerned about that. There's risks of financialization of patient data, and other things we need to keep an eye on. And while we've preserved access based on ability to pay, or excuse me, not on ability to pay for at least hospital and physician care, we're still seeing huge disparities in terms of how the pandemic is hitting folks based on other factors related to equity, right? Based on the type of job you have, based on the type of community you come from. It's, of course, we all know that the pandemic is hitting racialized communities harder. So these are all very real equity issues within the healthcare system that we need to address. And then, of course, there's the other topics that we're going to touch on later today, like prescription drugs, elder care, and mental health, that the pandemic has only shown us how urgently we need change.
Yes, I'm sure you'll have something to say about prescription drugs, so we'll just wait on. Now, Jeff, you're taking it from a different strand. Both Amina and Dan are practitioner. You're more in the academic, the advocacy role. What have you seen this pandemic create into? Where should we go?
Merci pour la question. Bonjour à tous. It's good to be with you all today. As a clinical psychologist and also as an academic researcher, we certainly see nationally the ever-growing demand in mental health and mental health services across our country, which has been made even more pronounced during this pandemic. One thing we know for sure is that whenever you have heightened degrees of social and economic inequality in a society, you have increasing rates of psychosocial distress, and that's certainly true in Canada. And certainly the various shortcomings of existing services across the country, but in particular in rural and northern and indigenous communities, as well as in urban centers, the lack of publicly funded infrastructure and services to support mental health and accessible mental health services for Canadians is so profoundly evident. Of course, the other component of that is that there are ways in which this pandemic has heightened our awareness of the various social determinants of health, the things that make one's quality of life more or less livable, are really being made so much more exposed. Things like inequity in housing, things like precarity of employment. These are the sort of day-to-day things that are part of what contribute to a person's quality of life, which are really conditions by which people can experience well-being. Those things are really profoundly challenged, and really the truth of the matter is that this pandemic has made abundantly clear that connected to major public health crises are also social and emotional and psychological demands. And I think Canadians are really coming face to face with that in new and important ways that are going to require our systems and our structures and infrastructure to catch up.
Yeah, you're bringing a good point on the mental health and what Dan talked about, virtual health. I'd love to hear during our discussion what you think about virtual services in mental health. We've seen a lot of that come out in the next year. So, but the question the Broadbent Institute asked me to ask you guys is, why did expanding Medicare stop? We know Tommy Douglas had a vision. It was to pay for doctors, pay for hospitals, but there was more than that. Why do you think it just stopped there, and it stopped quite radically? I'll start with you, Jeff.
Well, creating a dynamic and robust public socialized system of medicine, I think, is probably, it stops because it conflicts with the interests of a neoliberal economy. I think we have major corporate pressures toward privatization, and really many of the systems that would support a more dynamic, extended understanding of Medicare have really been seen traditionally as outside of kind of traditional core health practices and professions. And so part of it is about reframing what we mean when we talk about health, but also ardently defending the values of investment in social medicine, in part because it contributes to a healthier economy when you hold a broader picture of preventative health.
Mm-hmm. Yeah. Amina?
One of the things that always really strikes me is how dramatically life expectancies have changed overall in Canada. I mean, if you look back at 1950 in Canada, just around the time where Tommy Douglas was starting to implement hospital care coverage through the province in Saskatchewan, life expectancy then was 68. And life expectancy now in Canada is close to 83. It's so dramatically changed. I think that's a testament to how much of the country, not all of the country, has experienced incredible growth in access to water, medication, healthcare, which reflects that dramatic change. But our coverage has not reflected that. And much of our system is set up, particularly in the aging world, where we don't quite envision ourselves as getting old and sick. We think that happens to someone else, someone over there. And yet, just looking at dementia, I'm not even talking about all the other health issues that can happen. We're talking about 1 in 4 people after the age of 70 develop dementia, 1 in 3 after the age of 80, 1 in 2 after the age of 90. And dementia just itself can get really complicated, and yet our systems have not caught up to the realities of aging and what that looks like. That's in addition to, I think, what all of Jeff's reference to in particular around the neoliberal agenda, and also the fact that we have a system that moves incredibly slowly. We have an institution, and particularly in the way in which federalism is set up, the firming up those agreements and those transfers between the province and the federal government is extremely hard. And I think from the dramatic cuts that happened back in the 90s, in the mid 90s under Paul Martin as a finance minister, we've never recovered from that.
Yes, and I hate to admit it, but in the 1990s, I was also there lobbying. And back there, it was like we're doing it today. It was the shortage of healthcare practitioner. Some might remember that they had recommended to close the schools of nursing and close the schools of medicine. We had too much, then we hit a wall. But don't get me started. So I'll let Dan go on that. That was before your time, Dan. You were a baby doctor.
You know, Linda, the only person who introduces me more effusively than you do is my mother. So
She must be a great person.
you are so kind. Let me actually answer your question, though. When you look at the history of Medicare, right, the Medicare that we have, Medicare 1.0, it only guarantees universal access where people don't have to pay at the point of service delivery for doctors and hospitals. And I think it's because of what Amina said, you know, that we have that the way that people get sick has changed, and it hasn't changed because of what Jeffrey has also said, and that's because we have this neoliberal narrative around marketizing social services. The other reason why we don't have Medicare 2.0 community-based services is because of doctors. When you look at the history of Medicare and when it was formed, one of the biggest organized opponents to the Saskatchewan plan were physicians. Physicians went on strike and opposed the program bitterly. In fact, Saskatchewan had to bring in doctors from the UK and elsewhere to fill the gaps when physicians went on strike. And even the American Medical Association got in the act and supported the Saskatchewan physicians because they saw single-payer healthcare as such a massive threat, and they were scared that if it succeeded in Saskatchewan, it would succeed in Canada, and then that would have influence in the US. Now, you know, Douglas was obviously a very skilled political leader and politician, and he overcame that. But it happened at such a great political expense that he didn't have any political capital left to go to the next stage, to Medicare 2.0. And they had actually experimented with that in Saskatchewan, in particular in Swift Current, Saskatchewan. If you are interested in hearing like what that looked like, how even in the 50s and 60s, they envisioned a system that's even more advanced than what we have now. You know, go to your favorite search engine, type in Swift Current experiment, Swift Current Saskatchewan, Swift Current Medicare, and you'll get a sense of how even then, you know, we had the model of what we need now. But what's different now is that, you know, after Medicare came to be, doctors actually really liked the system because they weren't fighting insurance companies, they weren't fighting to get paid, they could focus on seeing the patient in front of them. And now many physicians are on the leading edge of expanding Medicare, right? So I'm the past chair of Canadian Doctors for Medicare. We've been a vocal voice, but other organizations like the Canadian Medical Association have spoken up in favor of it. Medical students are fantastic. The Canadian Federation of Medical Students have been a leading voice on this too. So we've definitely seen the narrative shift within organized medicine. That being said, of course, we're not all singing from the same playbook. There are also people within our profession who are making active attacks against Medicare. So we always have to be aware of those. But I think within my profession, we're at a different place than we were within the beginning, but we still have so much work to do to overcome the barriers that Amina and Jeff identified.
Yes, as Jeff mentioned, we love to live in a democracy, but we go with the waves of every 4 years of this democracy, and it can cause many headaches. Or, as the speaker in the previous panel said, the money is all the same color. That it goes for profit or that it goes towards care, it's the same money we're talking about. And we'll get into that when we talk about the recent federal budget. But if you'd have a solution to all of this, we know the gaps, and you can talk in your own feel of what the gaps are missing from our current healthcare system. I have my favorite universal pharmacare program, but how? And Dan, you would know that, but not our audience. But Canadian Doctors for Medicare was created following the 2004 promise on the Council of Federation on a national pharmacare program. So imagine we've been promised for a few years that. So anyway, go back to my speakers, Linda. The major gaps that you'd identify, and how would we fix it? Who wants to start? Now I see you all on my screen, so Amina, you smile first.
So, we need nothing less than a very dramatic shift. I think one of the things that concerns me always is the narrative around having to pick. It doesn't have to be either or. We don't have to pick between childcare, mental health, pharmacare, and seniors care. Especially, I think, I am willing to bet that probably I will never see a point again in my life where we have an opportunity to be able to actually invest cheaply in systems and in actually building our social safety net. And I will say that these silos are incredibly problematic in that there are so many intersections between them. I mean, most of my patients, for example, and their families, I mean, we're talking about people who are managing young children at the same time of having aging parents and having to deal with medications. I mean, we spend so much money, an exorbitant amount of money on medications for seniors, even though they're covered provincially, let's say, and by individual provinces. As a country, we spend a disproportionate amount, mainly because we just don't have a universal pharmacare program. Having a heavy investment in our social safety net, in particular, would really address a lot of these issues that we have.
Dan?
So let me talk about prescription drugs, because it's the area that I know best. We know exactly what we need to do. We've had report after report published on this topic. There's no ambiguity in terms of the steps. We have this federal government's commissioned its own advisory council on the implementation of pharmacare. I think that's the key point, implementation. It even laid out a timeline and a roadmap. So on this issue, there's no ambiguity. We know exactly what needs to be done. But for me, what has been really frustrating is that we haven't seen a level of commitment to get it done. I was so encouraged with this past federal budget on childcare because the federal government realized this was an issue, and they put money, they put their money where their mouth is. They put money on the table, and they're using that money to bring together the provinces to negotiate. But on pharmacare, we're seeing the exact different approach. We're saying, well, we need to get all the provinces and the premiers on board, and then we'll put money on the table. And I'm very concerned about this because we have never been as close to a universal pharmacare program than we have been now. But I'm very concerned that it's beginning to slip away because the rhetoric isn't matching the actual reality.
You're absolutely right. We've never been as close. We have a plan with timelines. The first timeline is essential drugs by 2022. And by the time they come around to doing anything, they'll tell us the plan is too old. We need to restart, research. It is frustrating. Jeff, do you have any wise words for us on this topic?
Yeah, I mean, I don't know. I can't promise they're wise, but they're certainly my opinion. I think in the domain of services and health structures and infrastructure in Canada, everybody will have their wish list. I think, we need to be thinking about expansion of pharmacare, dental, things like community mental health services, and we could go on about that. I think there are two real issues though that we're missing. One is to think about all healthcare services and service delivery through a more intersectional lens, which attends to issues like race, which attends to issues like language. The area of my work specifically focuses around Indigenous mental health and suicide prevention. And, we know that, this is the sort of area where the government likes to pass the buck and argue over whether or not who should be paying for these types of services when this is really, core to Canada's future is a healthy and vibrant Indigenous community. I think the second thing I would say is that we need to also have a more progressive conversation about what promotes healthy societies. Is not just expansion of services and expansion of coverage, but thinking about implementing the knowledge we have around social determinants of health, which would ask us to make much bigger investments in things that would actually prevent distress or prevent disease, prevent the types of health crises we see across the country. To think about investments in social and economic conditions that are conducive to our thriving is a very different type of conversation. That's not just about the expansion of services or putting a band-aid on distress, but really saying, we can reduce poverty, and we know that will reduce rates of disease. We can build housing, and that will increase overall mental health and decrease rates of psychological distress or addiction or substance use. There's so many things that are progressive social public policy that don't necessarily appear on their surface to be health policy. Those are also places where we need to be thinking and giving attention to.
So Jeff, roll into your analysis of the federal budget. How would you rank it on Indigenous issues, on mental health, on addiction? Let's stay away from childcare. I'm a childcare advocate. I was very happy, but I was stunned to see 30 billion, honestly. I thought we'd see, the crumbles they usually get. But on the two issues you mentioned, mental health, addictions, Indigenous issues, what's your
there's no doubt.
rate?
Yeah, there's no doubt about it. This is one of the more progressive federal budgets on the issue of mental health, and in terms of investments in Indigenous mental health in particular. I think what gets obscured in the details, though, is that most of that funding, particularly in places like Indigenous mental health, gets contracted out to private organizations and vendors. It's not going to supporting local health service infrastructure. It's not going to the support of education of Indigenous peoples in health professions. So I think there's a lot that kind of gets promised here, and in a political moment like the current government is in, it's one thing to promise the world; it's another thing to deliver it. And so I think we have yet to see where this goes. But I will say this: that the majority of investments in mental health services in Indigenous communities is really banking on the idea of telehealth and web-based services, which assumes a degree of access that we really can't guarantee in many First Nations communities across the country. And so while we can celebrate these large-scale investments, I mean, the current vendors that are and contractors that are essentially profiting from these investments are companies that are really disengaged with actual First Nations communities. So I'm sort of tentatively optimistic, but I think there's some reasons to be cautious about all the celebration about these commitments. And in terms of mental health investments, I mean, I think, again, we need to sort of think about a restructuring of our broader sense of what healthcare systems look like in order to see these investments have real sustainable long-term benefits. What I'm not super stoked, if I could use that term to describe, is the real lack in attention to harm reduction and immediate response to the current opioid crisis that we're facing across the country. I think there could have been a more progressive response to that than was given in this budget.
Amina, did you do an analysis of the federal budget, or you like all of us that are political nerds and watch the budget, read every line? Where did you see the shortfalls?
So of course, as me being the geriatrician, I've got that eye on long-term care, especially since so many of my patients are either waiting for long-term care or already in long-term care. The $3 billion for the entire country is paltry. It's nothing. And I think more importantly, however, um, the money itself was designated there to enforce standards. And what's appalling to me is that there's no mention there what minimum standards should be in the first place. In Ontario, we've been having a very long conversation over and over again about, at the very least, people within long-term care should be receiving 4 hours of hands-on care. And we don't even have that personal standard right now. It's well below 4 hours a day that people are receiving. And so if we can't even really uphold and decide what those minimum standards is, really the budget really meant a whole not of much of anything, really. I think the other thing that strikes me, and what to draw on some of what Jeff already just said, is that it's not just a matter of costs, it's also a matter of values. I mean, ultimately, from a basic economics perspective, every dollar we spend, whether it's privately or as taxpayers, ends up being a dollar earned for somebody else. And I think what we have a decision to make really fundamentally is, where do we want that money to go? Whose coffers and whose bank account do we want to fill? And so for me in particular, when I look, for example, at the state of home care in Ontario, it's very similar to what's happening in mental health, where there are a large number of private organizations that are really running home care in a very disjointed manner. So much of our costs, because we don't have a system that's conducive and continuous, ends up just being spent on administrative costs. None of it ends up being seen at the front lines by patients or by people who would need the services in the first place.
Sorry, I wanted to jump in because I just want to underline what Jeff and Amina just said. Like, this is really important. I want to make sure that the folks attending get this. It's not just about financing, right? It's not just about public financing or private financing. When it comes to public financing, it's really, really important for us to ask the question, where is this money going to, and who's it being delivered by, and how? So we heard from Jeff what that looks like, mental health care and Indigenous mental health. Amina just said long-term care. I alluded to it off the top, but this is happening right now in virtual care, where we're seeing all this additional public funding, but much of it is going to duplicate essentially walk-in style healthcare that is completely disconnected from primary care, which we know we need a strong primary care system to have high functioning healthcare. And the folks that are delivering that care are these private for-profit corporations, and really big ones that are making huge investments and consolidating the market, because they know it's much easier when you don't have to pay overhead for your own office or office staff. You just have to run the software. And that patient data is really valuable, right? Like, if you have a set of patients with diabetes, well, guess what? If you're a big grocer, you can throw in coupons for the blue items on your menu. So this is a very real and present thing happening in virtual care. The other place where we really need to be thoughtful and careful on is on wait lists. So the pandemic has created this huge backlog in elective wait lists because our healthcare system has been forced to pivot and respond and focus exclusively on a COVID-19 response. Now, as things begin to open up, we're going to have a lot of work to do to clear the backlog on things like hip and knees and cataract surgeries. The challenge is there will hopefully be public funding for that, but we may see it, and we are seeing it, being contracted out to private for-profit hospitals and other clinics. So in Ontario, we've seen the Doug Ford government do that on cataract surgeries. And in Alberta, we've seen the Kenney government do that for hips and knees. And I'm concerned that this may be for certain inclined governments, certain governments that are so inclined, we may see an acceleration for this outside of the pandemic. The pandemic's creating incredible opportunities, but it's also creating threats around disaster capitalism, and we need to be very aware of that.
Yeah, very in tune to mention it, because it is a worry. It is a worry for all of us that work in the system too, because you hear people saying, okay, I've waited 18 months for my knee, or 2 years, or what are the governments going to suggest next? It's also worrisome that some organizations are also promoting more preventive care, more primary care. I call it what is old is new again. We used to lobby a lot for community health centers. Are the community health centers going to become virtual? Because all due respect, Dan and Amina, it's more than doctors, eh? We need to make sure we have psychologists. We have to make sure we have pharmacists. We have to make sure we have nurses, of course. And how is all of that going to come virtual? Or are we going to look at some kind of community health centers and primary care? André Picard talked about community care. How are we going to take care of each other in community care? Are we going to transform our system? Is the public going to pay just for preventive community care and the private for surgeries? I don't know. I hope not, of course. But how do we see the movement of community care into our system now? Here, I'll go with you because a lot of the community care is about seniors, is about keeping them in their home, with, of course, safely and not alone. One of the speakers talked about, I think it was André Picard too, we're counting the deaths of COVID today, but are we going to be able to count the deaths of loneliness?
It's, the aging conversation, particularly around long-term care, is so interesting to me, mainly because we always talk about long-term care as being the last resort. And I think something that Pat Armstrong had said to me really stuck, which was this piece around loneliness, and is that some older patients, particularly, again, I see a lot of people who are extremely isolated, who may not have any family. Given aging and the way aging is at this time, I have many patients who have outlived their children. And those people just want to live in a community. And we don't have anything that actually accommodates that. So I think that's a huge challenge. In Ontario in particular, one of the things that happened before the pandemic is that Ontario moved towards reshifting the way in which healthcare is regionalized to Ontario health teams. I have a flicker of hope about that I will keep going. I'm not entirely sure if I am that optimistic given what the direction of this particular government is, but I think what the Ontario health teams offer us is an opportunity to make sure that services actually follow a patient and a person within the community rather than a person trying to follow the services. And that's where things get extremely challenging, is that there is no reason why a person needs to be spending all of their time trying to navigate how to actually get something like occupational therapist in their home, or physiotherapist in their home, or a pharmacist in their home. Let's be honest, the things that I can do for a person in advanced dementia is really limited. What really mobilizes me and enables me to be able to provide care is when I'm interdisciplinary and getting those people, the physiotherapist, the occupational therapist, the pharmacist, in the room with people. The only way you can do that is if that you start centering people for care rather than the other way around.
Oh, I love you, Amina. I'm just going to keep you. But, and the flicker of hope, we have about 9 minutes left as a group, and then they're going to pull us off stage. But that flicker of hope, how do we see it? How do you see it, Dan, moving into home care, community care? As a family doc now, put your doc hat on.
Yeah. People, I think Canadians, realize that this move into community care is long overdue. We've seen it with long-term care, with prescription drugs. We're now seeing all of the knock-on effects from the pandemic on mental health, come to roost. People are burnt out. I will put myself in that category. I'm feeling burnt out. And all the services that people need, whether they're delivering them or receiving them, they're community-based services. And I think people really will hold their governments to account on this. I think we are, as Amina said, not just in Ontario, but in other provinces, we're seeing healthcare being increasingly regionalized. And the locus of care is being moved outside of hospitals into the community. At the same time, the pandemic has also forced us to go back into the hospitals and appropriately so to deal with the acute care crisis. So I think, again, as the restrictions come down and as we make our way out of this, we'll also have to make sure we just as aggressively move out into the community, because we will need to make just as much of an effort to deal with the chronic care crisis post-pandemic than we have to deal with the acute care crisis that has occurred because of the pandemic.
Jeff?
Yeah, what gets me excited is the idea that in order for us to build transformative healthcare policy and progress in Canada and to create the types of communities of care that we're talking about today will require us to integrate existing systems that often function in silos. You can't support young people in communities without engaging educators. You can't talk about increasing the mental health of workers without talking about creating better economic conditions. You necessarily, to do community health well, you have to integrate a lot of parts of our public life that often function in isolation, and to make sure that we're investing in the types of people and communities that most significantly need our investment. I mean, all Canadians deserve quality healthcare, but it's not true that all Canadians experience healthcare equitably. And so I think, it's a really exciting opportunity for us to think as progressives about what it means to really deliver on equity that is doing justice in places in our society that have really been left behind or that have been altogether excluded. I think those are the places that I have hope, and I think the pandemic creates a window of opportunity for us to be accountable in those responses.
Mm-hmm. And we will have to ask so many questions as of society. What do we need? What do we exactly need? It's like when I do contracts for CFNU, I always ask my contractor, okay, give me the Cadillac model, the Volkswagen, and then, the Beetle. And then I'll decide what we need. And as society in healthcare, we will have to do that. When you think that the basic needs of seniors during this pandemic wasn't addressed, that is scary, disgusting, and embarrassing for us as a rich society. And as Dan mentioned, as healthcare provider, the burnout levels, the tiredness, every night you see most of them are all doctors in the Toronto region, and their eyes are dark down to there. You think they will need a break. We will all need a break. What encourages me, while we wrap up, and you can think of what encourages you, what is, maybe using Amina's word again, flicker of hope, but what encourages me is people like you. I've been around the block a few months now, and I've heard the Dr. Pat Armstrong for years and years and years. I've worked with her on long-term care. Some of you might remember Michael Rackless, Dr. Michael Rackless on community health, on community base, Steve Morgan in BC on pharmacare. And now we're seeing a new crop of activists talking the same thing we were talking 10, 20, 30 years ago. So that for me is a great hope that something will change. We just have to give a little bit backbone to some of our politicians. So I'll finish with you, Amina, because I started with you, but I'll do Jeff, Dan, and Amina, and your flicker of hope on where we can go for a better tomorrow. Jeff.
My flicker of hope for where we can go for a better tomorrow. I think that in this decade, we can achieve health equity in Indigenous communities if we have the political will and ethical commitment as a country to do it. And I see promise of that in Indigenous leaders and young people.
Yeah, you're right. my magicians, the Broadbent magicians that are helping us do this, are reminding those who are viewing on the other side, we can't see it, but there's a poll on how you as the viewers evaluate the federal budget. So please answer the poll while Dan gives us his flicker of hope.
For me, the flicker of hope is that our imaginations are broader than they've ever been in terms of the sort of society we want to build, and leaders who we didn't think were necessarily capable of having that imagination are showing that. We saw that, just yesterday with Joe Biden in the U.S. He's making pronouncements and announcements that I don't think progressives in the U.S. would have imagined he could have made when the last time he was in the White House, but in a different wing. And that gives me a flicker of hope here that perhaps there's a universe of possibilities here that we're closer to that we haven't been to before.
Maybe that's what we all need, is politicians that know they only have one term to make a difference and then they're off the racket. Okay, me mixing up in U.S. politics now. How dare I? Amina, since you started us on the flicker of hope.
Sure. I think the thing that gives me the most encouragement is seeing all of the local projects that are doing really incredible, innovative work at the community level. And I think we have a really incredible opportunity to start thinking about how do we scale it up. I think this has come up already, where really the Canadian challenge is scaling things up, but the imagination is there. We just need to start not being convinced that we have to choose and that all of it is an option. We can invest in everything.
Thank you. So we're going to wrap up by saying a big thank you to Dan, Jeff, Amina, and the Broadbent Institute and all the magicians that are making this happen. And make sure that you stay safe, you stay strong, 2 meters apart, wash your hands, wear a mask, and get vaccinated. That's how we will become a strong society, and use that flicker of hope Amina talked about. There's always hope as long as we don't tarnish the flicker. So please stay safe. Gros merci, Dan, Jeff, and Amina, and looking forward to seeing you in person.
Merci à tous.